Hey there guys, my name's Kris. I'm a general practitioner here in Australia and I have dealt with some deaths in my career. So I did 6 years of medical school and this is my 5th year as a doctor. So over the last 11 years I've been exposed to a fair bit. So fair warning, this video will be discussing death and dying. This may be triggering for some of you and I absolutely understand that if hearing this is not in your best interests, I will not be offended if you click off now. I do have 40 something other videos on my channel and more to come, so if you'd like to try and find something else to watch, you are more than welcome to. On that note, the patients I will be talking about today will be young and old, obviously de-identified, and I will be focusing more on the way that I process things in my journey in, relation to their journey. So just be aware that I won't be mentioning names or ages or anything like that if it's not relevant to the story. So in my personal life, so far, touch wood, I've only really experienced 2 deaths in my lifetime. One of them expected, one of them unexpected. So really, I've been exceptionally lucky. In my work career, however, I have lost count of the number of patients that I have seen dying, who have just died, or who are about to die. We all know that death is inevitable. Most of us are scared of death, and for good reason, of course. I know I'm scared of death, not just the fact that once I'm dead, that's it, but the process of dying. And in my work career, I have seen some very peaceful deaths, but I've also seen some tragic, horrific deaths, a few of them of which I will be talking about. So again, just a quick warning, if this is something that would be triggering to you or not within your best interests, time to click off. So sadly, the first death I ever experienced is probably the most traumatic and the one that will sit with me forever. I was a 2nd year medical student on a rural placement in the emergency department. I attended the hospital early that morning around 7 when I was only supposed to be there at like 8 because I was eager and interested. I remember walking into the hospital in the middle of winter. I was freezing. And I got ushered into one of the resuscitation rooms. I was told there was an active resuscitation needed and they needed me to become the scribe. So write down what was happening so that we could document later and refer to it later. The person being resuscitated was a 9-month-old boy. I remember it pretty vividly. Mind you, this was how long ago now? I was 19, so it was 9 years ago. I remember the colour of his face, I remember the smell of the resuscitation room, how many lines he had in, the tears of his parents, and I remember crying. Well, stifling my tears when I first met him, as in when I first walked into the room, but I remember absolutely sobbing when it was declared that resuscitation attempts were futile and that we needed to stop. There'd been 20 minutes, half an hour worth of resuscitation trialled outside of the hospital setting en route to the hospital, and we'd been going for about 20 minutes. I remember looking at the ECG, because obviously he was being monitored, and seeing activity. I didn't really know how to read ECGs at the time, so I don't remember if there was a rhythm or if it was just aberrant cardiac activity. But I remember talking directly to the leader of the team and going, "What are you doing, this cardiac activity?" And they had to take me aside after and say, "Look, yeah, there was, but it's not conducive to life." He'd been unconscious now, presumably deceased, for about 40 minutes, if not longer. 40 minutes without oxygen to the brain, or at least sufficient oxygen to the brain. It's not a good thing. So I now that I'm very far removed in time and I have a lot more experience and knowledge, completely understand what happened that day. But it was not easy. And I'm just very lucky that the team was very supportive of me, very thankful for my contribution, which felt like absolutely nothing at the time. And then I got to debrief with them. They said, if you want to go home, you can. I definitely didn't want to be alone. And yeah, it took me a while to feel confident walking into that room again as a scribe, as someone on the resuscitation team. But yeah, that was definitely the most traumatic, and I'll never ever forget it. I don't recall any further deaths when I was a student, although I have vague recollections of patients passing on teams that I was attached to. But the next death was also a rather traumatic one, and I'm smiling just because it's how I cope with emotions, sorry. I was an intern on the intensive care unit, and we had this gentleman come in off of a boat with necrotizing fasciitis, so a very, very serious infection. I remember one of the absolute gods of surgeons who came in and operated on him in the ICU to try and remove some of the dead flesh. Again, this isn't exactly a pleasant topic, is it? But I remember I was on night shift in one of my very first weeks, and I looked up and I saw that the ECG monitor started picking up a very, very abnormal rhythm. It was VF, ventricular fibrillation. And I turned to the registrar I was attached with and I said, look at that, and you go start CPR, I'm calling the boss. So I did. It was the first time I've ever done CPR, and that in itself was, it was a time. I've done CPR on several mannequins in the past, but doing it on someone else, it's completely different. It's easier, and I think that's mostly because of the adrenaline, but the chest compresses a lot easier than the mannequins, and the feedback you get's a lot better when you're going down. And yeah, I heard ribs crack, I heard everything. Again, pretty traumatic, but also very grateful for the experience. The bosses came in, we did 20 odd minutes of CPR on this gentleman. I tagged out with one of the nurses so we didn't fatigue. And at the end of it, despite shocks, despite CPR, despite all of the vasopressors and all of the drugs that we could give in the intensive care unit, this gentleman was deceased. And again, I remember walking away and crying. And I don't think that makes me weak at all. I think at the time I was very naive and very junior, and I didn't appreciate how much death would be associated with this role. Because as a doctor, we're so used to being the person who saves lives or changes lives, not the person who is there to witness the end of life. But that is just as important as all of our other roles. Thankfully, not all of the deaths in my career have been jarring. If I'm honest, I think it's really only those first two that really shook me, to use the term, not to be like all hip and whatnot. But a lot of the deaths that I've been witness to or a part of have actually been very peaceful. Death itself can be a very dignified and pain-free journey. Like I said, other than those two really traumatic ones, I've witnessed quite a few passings, and it's one of the most humbling, breathtaking, honourable experiences I've ever experienced. One of my roles as a junior doctor was to attend the room of the recently deceased and call their death, essentially confirm that the deceased had indeed passed. This is a legal procedure, and whilst it's not a very complicated procedure, it is definitely one that's not rushed, and it's definitely a very important one for obvious reasons. To confirm that the deceased has no signs of life, you initially ask for a response, so Mr. So-and-so or Mrs. So-and-so, can you hear me? Squeeze my hands. Then you try and elicit a pain response, because this is an inherent reflex as opposed to a conscious decision. So you might squeeze the traps, you might rub the sternum or push down on the nail bed. Once that's done, you check the pupils for responses with a pen torch or a pen light, and obviously, if they're deceased, there will be no response. And then you listen to the chest. And so for 2 to 3 minutes, you listen for heart activity, and one can concurrently palpate the carotid artery to see if there's pulse, or you can do that separately again. And then for another 2 or 3 minutes, you listen to the chest, trying to listen for breath sounds, so respirations. Once this is done, the death is legally confirmed. Now, appreciate that that patient may have deceased 5, 10, 15, 60 minutes prior to you actually attending. And then you add on the extra 5 minutes for you to actually process the deceased and ensure that, the legal documentation is being filled. So the time of death on the certificate may not reflect the actual time that that person deceased. This is more of a legality thing. Obviously, if you attend a scene and someone's been decapitated or whatnot, you might not have to go through that whole process to confirm a time of death. But it is very interesting, because opposed to time of life, it's basically when the body is out of the vaginal cavity or the abdominal cavity, time of death is very different. So just because the procedure of calling a death is simple, it doesn't mean it's not humbling. It can be an extraordinarily jarring situation to be in, to see a patient lying there unresponsive. Perhaps you knew them when they were living, treating them or otherwise, and it's really bizarre. It's humbling and it's definitely a privilege, but it can be confronting. They often look frozen in a moment of time, sometimes like they're sleeping, sometimes like they're mid-sentence. And when you're listening to the chest or feeling for the pulse, often you'll hear your own breathing and feel your own pulse or hear it. And you have to really be able to separate oneself and know what you're listening for and be confident in your decision for obvious reasons. I remember one night I was on night shift and I had to attend to the same person to call their death 3 times because they had monitors on, we were expecting them to pass, and the nursing staff, who aren't trained in calling death, it's not their role, would say, look, we think that there's no more activity of life. The family were, happy with that call, so I would come down. But as I was listening, I'd hear 1 respiration, or I'd hear, 4 beats a minute, something non-conducive with life, but there was still activity of living. And so I would have to turn around and say, not yet. And I'm smiling about it now because they were very, very lovely about it. There wasn't that emotional, what do you mean they're still alive? It was, okay, he's not passed yet, that's okay. But I can imagine that the same circumstance with a different family might have been absolutely different. On that note, that's always been the hardest part. Talking with the families and telling them their loved ones are deceased and no longer here. Sometimes my job as a junior doctor was to call family to say that we expected a loved one to pass, or that they were actively passing, or if they just passed. It's not an easy phone call to make, and my goodness, I can't imagine it's an easy phone call to receive either, don't get me wrong. It never gets easy, but it does get easier. One of my most cherished memories with a patient regarding a death was sitting with a loved one outside of their room after I'd called the death and just letting them talk to me about their loved one. I didn't make any difference to their care, I didn't, change this woman's life or anything, but it was cathartic for both her and myself to be thankful for the living moments that this person had. And again, it was just humbling, and it just made me realize what a privileged position I was in to step into these people's lives and to make such big calls. I'm calling them deceased. It was something I'll cherish forever, although I can't imagine she remembers me or remembers what happened. People respond differently to death. I've had patients, family members who cry, who scream, who say thank God, who celebrate, who are happy, who are sad, and seem indifferent. None of these is correct, and none of these is wrong. It's all circumstantial. It depends on what was happening, if it was expected or not. But it's very interesting to, oh my goodness, to bear witness to all of this. So, how have I dealt with death? Well, for one, I journal, and I do have a whole series about the rotation diaries, or diaries that I kept throughout my junior medical years. And I think I've told a few of these stories in that series anyway. Secondly, I've always been a talker. Shocker, I know. So I've always been open about asking questions and debriefing with the team afterwards. I know personally if I internalize things or if I don't talk about them, they eat me alive. So talking about it is very cathartic to me, and it helps me process what's happening. I've also learned to think of dying as part of my job. Like I said before, we always associate medicine with living or keeping someone alive, but it's not always. It sounds cold, but I wouldn't be a good doctor if I got emotional about every death or every dying patient. So I have come to think of it as another part of the job. It's protective for me and also for my patients because I can be level-headed when I'm treating them. My role as a doctor and now as a GP isn't always to save lives, but it is to keep people pain-free, informed, maintain their dignity, fulfill their wishes as much as possible, and to be there, to listen, to guide, or to otherwise just be another ear and a shoulder. One part of a GP's possible ways of caring for a patient is through palliative care. So palliative care does not always mean the process of dying or the care of the dying, but it can do. Our role in palliative care is to maintain the dignity of the patient, keep them pain-free, reduce their anxieties, and essentially ensure for lack of a better term, a peaceful passing. Our main role is to fulfill as many wishes of the patient that we can. Often patients are given a subcutaneous pump full of medications. I often call them M&M, so morphine for pain and anxiety, midazolam to keep them not aware necessarily of what is happening, and metoclopramide to help with the nausea and secretions that can come in the process of dying. We're not killing them, that's a very, very important thing, but we're ensuring that dignified, pain-free, anxiety-free passing, like I mentioned. Something I encourage all of my patients to do is fill in a piece of paper called the Advanced Health Directive. I especially encourage my patients to fill this in if I know that I wouldn't be surprised or shocked if I heard that they had passed away in the next 12 months. Mind you, you don't have to be close to death to fill in an Advanced Healthcare Directive. As a 28-year-old woman who's relatively healthy, I should probably have an Advanced Healthcare Directive. I need to book in a double appointment with my GP for that. An Advanced Healthcare Directive is essentially a list of your wishes and what you would and would not want as part of your care if you could no longer make the decision for yourself. It can be things like I do or don't want intravenous drugs. I do or do not want a breathing tube or ventilator. I do or do not want life-saving surgery, CPR, electrical shocks during CPR. It's basically finding that ceiling of care. It is a legal document, it has to be done properly with a general practitioner and then someone as a representative of the law, whether that be a justice of the peace or a lawyer. And essentially it doesn't come into play until you are not cognizant enough to make your wishes known. You can also elect someone in your life to be an enduring power of attorney. That is to say, someone who makes the decisions for you when you no longer can. This is slightly different, but is very well integrated in the Advanced Healthcare Directive. The final piece of paper that is associated with all of this is something called a statement of choice, which is exactly what it sounds like. What are your choices? What would you like done? All of these, of course, are holistic in the sense that they ask for spiritual and religious beliefs, what you do or do not want, who you do or do not want contacted if you are hospitalized or otherwise dying. So it sounds very callous, do you want IV drugs? But really, it can be quite a nice process for families to go through, albeit I admit, it can be very, very confronting. Now, there has been a lot of discussion in the media recently about something called euthanasia or assisted dying. This is very different to assisted suicide, and the main difference is assisted dying, the doctor or the practitioner involved is the one who makes the process happen. Whilst in assisted suicide, the tools are given to the patient and the patient completes it. Now, I'm not here to tell you what to think, what to believe in, where your belief should be. I'm just here to tell you what the facts are. And the facts are that in Victoria, all of this is legal, and very soon in Western Australia, this is legal as well. It's definitely not an easy thing to organise, and it's not, oh, yep, cool, we're going to do euthanasia now. It's a very complicated process. So yeah, I have seen people die. I have seen sudden deaths, painful deaths, dignified deaths, pain-free deaths, expected deaths. I've seen a lot, and mind you, I haven't seen as much as some of my colleagues would have. I've been the doctor to decide that a patient is deceased more times than I can count. I have a role now in the community as a general practitioner to assist people in making choice and to ensuring that if they are passing, they can do so pain-free. Death is inevitable, and it is scary, but it doesn't always have to be. I hope you found this useful, and if there's any other taboo subjects you want me to touch on, please let me know. Again, I'm not here to make choices for you, I'm just here to inform you. Consider subscribing if you haven't, leave a like, leave me a comment, and until next time guys, stay safe, stay healthy, and I'll see you later.